Hello, I'm Dr. Ronald Jenkins. I'm a cardiologist, and I'm also the medical director for Bonner County EMS system. Have been so for the last 4 years, I believe. And I'm here to speak to you about the STEMI program. STEMI stands for ST elevation myocardial infarction, heart attack, garden variety heart attack. So we have instituted a program over the last few years which really has made a radical change in how we in Bonner County manage this type of heart attack, ST elevation STEMI myocardial infarction. And let's go back a few years and look at the problem. When I first came into this town in around 2005, the management was somewhat difficult, and perhaps the word is abysmal. And what we noticed that we could not get people from Bonner County down to Kootenai County, where Kootenai Medical Center is, where we could do primary angioplasty to stop a heart attack in its tracks. What we really needed was the ability to take people from the point of presentation, their homes, their place of business, and secondly, if they were brought to the hospital or came to the hospital on their own accord, and we discovered they had a ST elevation myocardial infarction, we wanted to take them directly from the emergency room down to the catheterization lab at Kootenai Medical Center, and we wanted to do it, quickly, within 15 minutes or so. And so that was our goal, and we set out and we looked at all our options, and the best option was to train our paramedics to a critical care transport level. And so we undertook that in 2010, and we were successful in getting the paramedics up to speed. That meant that the paramedics could now give virtually all the medications that are given in the emergency room when people show up with heart attacks. Specifically, we got Kootenai Medical Center to agree to take all STEMI patients sight unseen straight to the cath lab, whether or not somebody spent 20 minutes looking for a bed, which was previously what would happen. You'd call and they'd say, well, let me think and see if we have a bed, hold on, and time would go by. And now it's, no, we'll take the patient absolutely positively, and we'll work on finding them a bed after we open the artery and they're out of the frying pan, so to speak. We figured out how to transmit EKGs on our smartphones. What a great idea. And all of a sudden, the cardiologist can see exactly what's coming his way. Sometimes they needed to be stabilized in the emergency room, but every minute spent in the emergency room is really minutes off the outcome, which is open the artery as fast as possible. All the data in the world has now shown the faster you open an artery, the better the outcome. So we instituted this protocol November 1st, I believe, 2010. And we looked at the data for the previous 2 years, and then after 1 year, we looked at the data to see how we did. And in fact, we did fabulous. And a huge effort is due to the fact that the paramedics from Bonner County EMS made this happen. Everyone else played ball and they facilitated this, but the paramedics made this happen, and it's fabulous to see. So what we saw is the door to balloon time. That is something that we track in circles of those who look at interventional cardiology statistics. Door being really, in this case, EMS to when we open an artery. So the moment the patient sees an EMS person, whether in an emergency room or a paramedic in the field, and to the moment the artery is actually open and blood's flowing and the heart attack is stopped. So what we were able to show is that our door to balloon time went down from 183 minutes to 104 to 107 minutes. So all of a sudden we were where we really needed to be. Complication rate went down from 42% to 5%. So all of a sudden people did much better. They went home sooner, and that was a huge improvement. It's been an excellent program, and I'm very pleased with the genuine efforts by the BCMS paramedics, by the administration, by the county who supported this, by Bonner General who supported this, by the emergency room physicians, both at Kootenai and at Bonner General, and by the cardiologists that are appreciative to hear about these patients ahead of time, and such that we can be ready to take these patients at the moment they show up at the hospital. We keep looking at ways to improve things. And so we're still trying to figure out the very best cocktail of what do you give a patient when they're on the way to get an artery opened. Along comes a drug that's being studied called Cangrelor. Anyhow, this drug is an equivalent of an intravenous Plavix-like medication. If this drug pans out, which the studies that were presented in March in San Francisco at the American College of Cardiology, those studies go to the FDA. If the FDA agrees, then this drug becomes marketed and will probably be our go-to drug on the ambulance to be given to these patients while they're en route to have their arteries opened. Probably the one big piece that we really, really need is education of the community. And that's a tough one. And that is getting people to understand the symptoms of heart attack, getting them to know that if they call 911, EMS will come to them and start the right medications. It appears that still 75% or so of people with heart attacks are sitting around at home for an hour or two doing the denial thing, hoping the symptoms will go away. They finally realize that, okay, this is the real thing, and then they have someone drive them to the emergency room. And that is, I understand it, that's the way it's been for a long time, but if you can get a paramedic to you faster and they can bypass the emergency room, your outcome will be better.